Hey everyone, and welcome. Let's just jump right in, shall we? Today we are taking a really fascinating journey into the complex world of medical documentation. We're going to unpack exactly why clinical queries matter so much, how they ensure documentation clarity, and ultimately how having more text on the screen, meaning more precise, detailed notes in the electronic health record, leads to a proper understanding of the patient's condition, which properly increases your coding accuracy. We're relying on a fantastic source text today that breaks down the very real challenges coders and providers face when trying to translate vague medical records into highly accurate, defensible data. So let's get started. Right off the bat, let's look at the core conflict professionals deal with literally every single day. A condition is cited in the clinical record, but was it actually treated? Did it truly impact the patient's stay? Did it meet the strict criteria for a secondary diagnosis? It's kind of like a detective story, right? This is the fundamental mystery we're trying to solve. You might have a medical record that's super vague, and that stands in stark contrast to the actual physical clinical reality of what happened in the hospital. Okay, let's dive into this. Here is the roadmap we'll use to solve this documentation mystery. 1. The vague documentation problem. 2. Spotting vital clinical indicators. 3. CMS guidelines and resources. 4. The power of queries. 5. Clinical validation versus coding. And finally, 6. Achieving true coding accuracy. So, Section 1, the vague documentation problem. Let's look at the initial hurdles coders face when reviewing a patient's medical record. Listen, assigning an ICD-10-CM code solely because a condition was mentioned just once in the record, that is highly ill-advised. And this is absolutely crucial when that condition carries what we call CC or MCC status, meaning a complication or comorbidity or a major complication or comorbidity. The great irony of medical coding is that a patient can physically have a totally life-threatening condition, but if a doctor doesn't write down the treatment clearly, well, actually, to the coder, it simply didn't happen. You cannot just see a word on a screen and assume it warrants a complex code. The documentation has to be completely clear and verifiable. If it's not, you are introducing a massive amount of risk into the coding process. Because here's the thing, if you claim a condition was significant, auditors are going to come looking for proof. What do they expect to see? They expect explicit text-based evidence that the condition warranted treatment. They want to see more text on the screen, proving the attending provider actually acknowledged the condition. Plus, there needs to be a clear reference to the provider who is actively managing it, right alongside clear documentation of the associated treatment. If auditors don't find these specific items written out in the medical record, failing to query the provider for clarification is going to cause serious issues. This is why text clarity is paramount. It's literally what protects the hospital from audits and ensures quality patient care metrics are captured accurately. Moving on to Section 2, spotting vital clinical indicators. You've really got to think of the medical coder here as a detective, actively scouring the record for vital clues. These clues are what the source text calls clinical indicators. They basically alert coders to conditions that might represent a CC or MCC and warrant further clarification. Coders have to constantly be on the lookout for documentation of high-stakes, life-or-death situations, things like cardiac arrest, respiratory failure, or diabetic ketoacidosis. They also need to spot evidence of organ system failure, like acute kidney injury or liver failure. And finally, they have to identify acute exacerbations of chronic illnesses, such as acute on chronic congestive heart failure or worsening cancer. These aren't massive red flags that a higher level of care is being administered. But here's the catch, and it's a big one. Often, all the signs, all those critical indicators we just talked about, are totally present in the record. The lab results might be there, the medications are listed, but the actual diagnosis itself, it isn't captured to the necessary degree of specificity for correct code assignment. Finding the clue just isn't enough. If the documentation isn't specific, it directly warrants a clinical query to bridge that gap. Let's hit Section 3. CMS guidelines and resources. How does the overarching regulatory framework actually view these clinical indicators? To really understand this, we have to look to the Centers for Medicare and Medicaid Services, or CMS. In the fiscal year 2021 Inpatient Prospective Payment System Final Rule, CMS identified 9 specific guiding principles. These principles serve as direct markers of increased resource use by secondary diagnoses. The source text outlines these in detail, and honestly, they're absolutely essential for understanding exactly how CMS categorizes these complex situations. Now, what's really fascinating here is how incredibly precise the CMS terminology is. Let's break down the first 5 principles. Number 1 is end of life, where the patient has reached an advanced stage associated with systemic physiologic decompensation. 2 is organ instability, which denotes organ system instability or outright failure. 3 is chronic illness, meaning a condition with susceptibility to exacerbations or an abrupt decline. 4 is advanced disease, which serves as a marker across multiple different comorbid conditions. And 5 is a condition reflecting an overall systemic impact on the patient. These exact descriptions are what justify why a hospital is utilizing more resources to care for somebody. Continuing with the final 4 principles. Number 6 is a postoperative condition or complication actively impacting recovery. Number 7 is a condition that typically requires a higher care level. We're talking intensive monitoring, more caregivers, ICU care, or an extended stay. Number 8 is a condition that impedes care, whether that's patient cooperation or the overall management of their care. And finally, number 9 relates to practice changes, specifically recent changes in best practices that have led to expected changes in resource use. If a secondary diagnosis fits into any of these buckets, it is a major indicator of resource consumption. Section 4. The power of queries. We know the rules, we know the principles. So how do we actually fix the problem of vague notes? As our source material points out, with the emergence of Medicare Severity Diagnosis-related groups, or MS-DRGs, the devil is truly in the details. Feathering out diagnoses to their absolute highest level of specificity is no longer just optional, it is mandatory for true coding accuracy. You simply can't guess. So how do we get that specificity? We follow a really logical step-by-step process. First, you identify the clinical indicator in the chart. Second, you collaborate. The coder and the clinical documentation integrity professional have got to work closely with each other and the provider. Third, you issue an appropriate query to clarify that vague documentation. And fourth, through that query, you establish the necessary specificity linking the diagnoses to conditions that support a CC or MCC assignment. This step-by-step query process is what clarifies vague text, giving us more precise text on the screen, which directly creates the foundation for true coding accuracy. Section 5. Clinical validation versus coding. This is a crucial distinction. Because honestly, even seasoned professionals can sometimes blur the lines between these two concepts. Let's contrast these two ideas. Traditional DRG coding validation is basically about making sure the codes accurately reflect what is written in the documentation. Clinical validation, however, is an entirely different beast. It's about reviewing the case to see if the patient actually physically possesses the condition that was documented. Because clinical validation is looking at the medical reality rather than just the written words on the screen, it generally requires a review by a clinician or someone with expert clinical encoding knowledge. And this brilliantly illustrates that exact point. Look at the CMS Statement of Work for the Recovery Audit Program. It firmly establishes that clinical validation is a separate process to see whether or not the patient truly possesses the conditions that were documented. CMS guidance notes this is beyond the scope of traditional coding validation. While coders rely on provider documentation, queries remain an absolutely essential tool when the documentation lacks the clinical support needed to accurately and defensively report a diagnosis. Finally, Section 6. Achieving true coding accuracy. How can hospitals practically apply all of this information moving forward to ensure defensible reporting? Well, success really comes down to 4 crucial keys. First, do not rely solely on diagnosis lists generated by AI or computer-assisted coding tools. They are helpful tools, sure, but they are not the final authority. Second, never use diagnostic criteria to assign a code in the absence of a provider-documented diagnosis. Remember, a coder cannot diagnose the patient. Third, use your specific hospital policies and diagnostic criteria to identify exactly when a query is necessary. And finally, carefully monitor claims denials for CCs and MCCs. Using that denial data allows you to course correct and pinpoint exactly where your providers might need a bit more education. Which brings us to our final thought for this explainer. Success here requires a really delicate balance of documentation specificity and clinical clarity. Provider education is absolutely paramount. But ask yourself this, are you educating providers to capture diagnoses for true clinical accuracy or simply capturing them for higher reimbursement? Prioritizing the integrity and accuracy of the medical record is what ultimately creates a defensible, highly accurate system. Thank you so much for joining me on this deep dive. Keep asking those right questions, keep seeking clarity, and I'll see you in the next explainer.